Good afternoon, and welcome to Ask the Doc. This is the monthly program where we give our audience the opportunity to ask our experts questions about Alzheimer's disease and dementia. My name is Dr. Megan Whitbracht, and I'm the Associate Director of Education for the University of California, Irvine Institute for Memory Impairments and Neurological Disorders, or UCI MIND. UCI MIND is part of a national network of Alzheimer's disease research centers that are designated by the National Institute on Aging, or National Institutes of Health. So every year, we usually do a few shows where we give you updates on, for example, approved drugs or therapies or blood tests, things like that. We thought it would be fun this year to give you a show where we do advances on the field, but we wanted to put it in the middle of the year when we come back from our big annual conference, the Alzheimer's Association's International Conference, or AAIC. Again, this is a huge conference that many of us at UCI MIND attend and present at. In fact, this year, it was in Toronto. It was attended by 8,000 people in person and another 3,000 people online. And it's attended typically by scientists from industry and academia, physicians, and to a lesser extent by patients, advocates, and caregivers. And what goes on at this conference is talks, a lot of talks, short talks, 4 minutes to plenary talks that are 30 minutes to 45 minutes or so of scientists presenting their work. And then poster presentations of 1,000 or more each day of this 5-day conference. And then finally networking that goes on where scientists are and physicians are collaborating. And so to talk about updates or advances that are occurring at this conference, we have Dr. Joshua Grill. Dr. Grill is director of UCI MIND. He is also professor of neurobiology and behavior in the School of Biological Sciences and professor of psychiatry and human behavior in the School of Medicine at UCI MIND. Welcome, Dr. Grill.
Hi, Megan. Thank you for having me. Hello to our UCI MIND community of followers.
So maybe the first question to ask you is, what were your general impressions from AAIC this year?
Sure. Well, let me begin by saying it's great to be back on Ask the Doc, Facebook Live and through other platforms. We did have a great turnout for UCI MIND attending the AAIC, the Alzheimer's Association International Conference, as we do every year. I think, where I'll begin is to say that personally, I feel like an important culture shift may be occurring. I feel a real sense of optimism about the progress that is being made in the field. And that optimism was tangible at the conference. Now, as you pointed out, there were a lot of us there, 8,000 plus investigators and advocates. But I feel like we are really moving the needle. And I think that moving the needle comes from the research progress, and we'll talk about treatments and we'll talk about diagnostics. But I hope that it's going to bleed into other elements of our culture as a society and as a global society. And what I mean by that is it's really important that we remove the stigma around Alzheimer's disease and dementia, that we aim to become a dementia-friendly society where it's okay to talk about these things and to acknowledge the struggles that families are living with and going through, and the experience of a loved one progressing through these diseases or facing cognitive and functional problems that result from these diseases. And for me, at least, I just felt like we were further along than ever before in a lot of those really critical conversations. Our goal, of course, is to make discoveries to better understand the many diseases that cause dementia, to use those discoveries to improve the diagnosis and care that older adults can receive for these conditions. But a bigger goal is to change the way we think about these diseases, to change the way we talk about these diseases, and to, I'm repeating myself, but to remove those stigmas that currently exist in our society. And ultimately, I think that to truly be successful as researchers, to genuinely find solutions for these diseases, in parallel, we have to make those societal changes. Much of what we're doing is aiming at early intervention, and we hope someday prevention, and the societal elements of making the changes in the way we think about and talk about these diseases will have to come hand in hand. So AAIC, it's a huge conference, 8,000 plus people, and many more online, but it's still just the tip of the iceberg, right? Those are the people who've devoted their lives professionally to studying these diseases. But thankfully, the Alzheimer's Association does an incredible job of garnering attention for the work that's being presented. We see a lot of headlines in the media throughout the week and thereafter. And I really hope and believe that these types of conversations, this type of sea change happening at the tip of the iceberg is going to start to permeate throughout the rest of our society. And while we saw some great data and some exciting updates, that was one of the things that I really left with as I returned back to California from Toronto.
Yes, I agree. I left with that same feeling. So let's talk about some of those highlights. And oftentimes in the news, at the end of July, beginning of August, a lot of people may notice there's a flurry of news about Alzheimer's disease, and often it's coming because of AAIC. So one of the headlines that came out of AAIC this year were top-line results from the Pointer study. Can you tell us what the Pointer study is and what researchers from that study found?
Sure.
Okay.
So yes, I would say the thing that generated the most buzz and the most headlines in the media was the top-line results of the U.S. Pointer trial. The U.S. Pointer trial was an Alzheimer's Association-funded clinical trial, although the investigators did an incredible job of garnering a lot more funding for maximizing the scientific value of the trial. This was a randomized controlled trial, so we think of this as the gold standard type of investigational study to generate evidence around an intervention. The intervention in this case was a multifactorial lifestyle intervention. So folks were given guidance on exercising more and better, eating a healthier diet, specifically the MIND diet, and I can come back to that, engaging in cognitive exercise or cognitive training using some online programming to work out your brain, and medical oversight as well. So managing the chronic conditions we know can put the brain at risk for late life problems, including dementia, like high blood pressure, high cholesterol, and the like. So that was a combined type of intervention. Folks got all of those things, and they were randomly assigned to get those things in a very structured, guided way with relatively high oversight by the investigative team, or those same types of recommendations, but in a more self-guided approach. So there were only two arms. Folks either got the guided approach, or the structured approach, or the self-guided approach. These were very much anticipated results. The U.S. Pointer is one of numerous clinical trials happening around the world in what's called the worldwide FINGER studies. FINGER was a Finnish study that really set a unique precedent several years ago now of showing that these lifestyle interventions can actually help improve cognition in older adults who don't suffer from dementia. So people were very excited to see these results. Everyone knew they were coming, and I would say they didn't disappoint. First, I'll say they did an absolutely fantastic job of putting together a session to describe the results. The study was led by numerous investigators. It was conducted at 5 US sites. The principal investigator is Laura Baker from Wake Forest University. She and her colleagues who led this study really put together an outstanding session that was, keynote, if you will, at the AAIC conference. One thing I will especially applaud from them was that they involved some of the participants in the trial in the presentation of the results. I thought that was just an absolute stroke of genius and great of them. But most importantly, they got to present results from a positive trial. So in the study, the primary outcome measure was how people were doing on cognitive tests. And over time, both groups showed improvement in cognitive performance while they were enrolled in the study. But the group that was randomly assigned to the structured approach showed greater improvement than the group that was randomly assigned to the self-guided approach. So, a couple of other important things to say when we do clinical trials. Other key things include our rigor, our replicability. Some of those things, like replicability, will come from other studies like this. And it's also important to say that these were folks who were deemed at increased risk to someday develop cognitive problems and dementia. Some of them had cardiovascular risks and family history of dementia. And that the investigators did a really good job of recruiting quite a diverse sample into their study. And so historically, we don't always do a good job of having representative samples when it comes to things like education and race and ethnicity. And this study did a better job than most of our trials historically. So to have positive results, to have it from a diverse sample, it was very celebrated, and appropriately so. And the data, the results overall, really reaffirm a lot of what we have been telling people to this point, which is that if you want to protect your brain, if you want to maintain your cognitive performance in older age, there are easy recommendations that we can and do make, like staying physically active, getting exercise routinely, eating a healthy diet, this case, the MIND diet, which is a combination of the Mediterranean diet and the DASH diet to lower hypertension. That's a combination of things you do want to get in your diet, like regular consumption of fish, dark green leafy vegetables, fruits and berries, along with things you want to lower or remove from your diet, the foods high in fat and cholesterol, the red meats and the like. So keep doing those things. And if you're not doing them enough, do more of them. Keep an active brain, challenge your brain, learn a new language, learn a musical instrument. And of course, if your blood pressure is high or approaching becoming high, if your cholesterol is high, especially that LDL cholesterol, work closely with your doctor to go on treatments that keep those things lower and in the healthy ranges. And the last thing I'll say about this, while these are very exciting and important findings, they do reaffirm recommendations that we routinely make and that we make free of charge. And so, there's really no need to subscribe to expensive programs or supplement the diet with additional things that, cost money and have no evidence to support them, really. These are things that we will tell everyone for free, and that we hope everyone will routinely undertake who is concerned about their brain health especially.
Excellent. Okay. Another major focus of the conference was blood biomarkers, as these tests are becoming increasingly used in a clinical setting. The association released clinical practice guidelines for blood biomarker tests. Can you help us understand where blood tests are right now and what these guidelines mean?
Absolutely. So again, I have to applaud the association for leading on this topic and bringing together a group of experts to produce guidelines around blood biomarkers. And, blood biomarkers were once a fantasy in Alzheimer's disease research, and now they're a reality. We have blood tests that can hold real value in the clinical workup and care of older adults who are suffering from cognitive problems. These are now entering into clinical practice, and that's a good thing. And the guidelines that were produced, I thought, were extremely reasonable. First of all, the guidelines made clear that these are tests that shouldn't be used on their own. They are part of an expert workup in the hands of a qualified clinician who's caring for older adults with cognitive problems. There are many tests at this point, and multiple tests are available in practice, and all tests are not created equal. And so clinicians need to take care that they are implementing tests for which the results are reliable and accurate, and the accuracy, specifically the sensitivity and specificity of these tests for detecting what we consider the gold standard tests, that is PET scans to detect amyloid plaques in the brain, or cerebrospinal fluid protein analyses to look for whether a person is exhibiting the characteristic changes we associate with Alzheimer's disease. The accuracy for predicting those outcomes is quite important. Clinicians differ in their attitudes towards these tests. Some think that they are good for screening and identifying people who are appropriate for those gold standard tests. Others feel like in certain circumstances, these blood tests may be enough on their own to determine that a person does or does not have Alzheimer's disease as the cause of their cognitive problems, and even to begin treating Alzheimer's disease, if that is the diagnosis, with anti-amyloid therapies that are now also available, and I'm sure we'll talk more about. The guidelines offered specific recommendations around sensitivity and specificity for whether tests should be used as screeners versus might be independent. But that's really going to boil down into clinical decision-making for experts who are skilled in the workup of patients with cognitive impairment to decide how best to use these in their practices. And again, I think what's going to be most important is to see head-to-head comparisons, and we've already had several of those that demonstrate that these tests are not all created equal. Other things are going to come into play. Does insurance cover the test? That's going to be a key decision. And so hopefully this guideline is a step toward a longer, bigger vision of clear parameters around using these tests as part of the workup for people with cognitive impairment and for things like determining whether people should go on anti-amyloid therapies. Now, a couple of really important caveats. One, we don't have enough of these tests yet. So we have some tests, they look incredibly promising, and they're most promising for telling us whether plaques and tangles are accumulating in the brain of a person with cognitive problems. Plaques and tangles are, of course, synonymous with Alzheimer's disease, but there are many causes of dementia, and over time, we will hope to have blood tests that give us information about the other causes of cognitive impairment in older adults. For now, we only have tests that really help us understand whether Alzheimer's is causing those problems, and it doesn't give us information about the other potential causes. And maybe we'll come back to it later, but the guidelines are also very clear that these are tests for people with cognitive problems who are being evaluated to understand those problems. They are not for people who are just interested in learning if they might someday develop dementia or develop Alzheimer's disease. They are not for cognitively unimpaired older adults.
It's funny, I gave a talk last night. The two questions that came up about blood tests were, does insurance cover them? And when will I have a test to cover a screening for Alzheimer's disease? So this is definitely top of mind for people.
Yeah, and it's certainly top of mind for me as well. And we're trying to get a paper out pretty soon, because another thing that is happening is that companies are starting to market these tests direct to consumers. And I have real hesitation and frankly concern about that. These tests are not all created equal. The companies that are doing this are not very transparent about what tests they're using or what threshold they're assigning for when a person does or does not meet some sort of criteria. The companies may or may not involve clinicians in the process. And again, these are not tests, even for people with cognitive impairment or without it. These are not tests to be used as standalone instruments. They're only valuable in the hands of a skilled clinician. Mm-hmm. When the companies do involve clinicians, my sense is that they use them after the fact, that is, after a person has had the test to help a person interpret the results. But really, we feel like education and counseling and clinical guidance is essential before a person would decide to undergo biomarker testing for Alzheimer's disease. Some of this is because of what we began with, the stigma and some of the legal risks that exist for people if they've been labeled as having Alzheimer's disease. And again, I hope someday that'll change substantially, where a lot of those risks will no longer be the case. But even in 2025, there are real risks that accompany having these tests, having them in your medical record, or otherwise having a label of Alzheimer's disease associated with the person. So we've got work to do. But again, the overarching thing is that this is tremendous progress, that these tests are in some ways a dream come true to really increase access to diagnosis, increase the time to diagnosis, and increase confidence when a clinician makes a diagnosis about what the underpinning cause of a person's cognitive problems really is.
Great. Let's move into disease-modifying drugs. We now have about 2 years of real-world experience with approved disease-modifying drugs like Leqembi, and 1 year with Kisunla. There were a few sessions focused on clinical experience with these medications. Do you want to comment on what was discussed in those sessions in terms of safety, effectiveness, and patient experience?
Yeah, you said it. There are 2 drugs that are now have entered into the clinical practice of caring for older adults with cognitive problems caused by Alzheimer's disease. I usually use their generic names because that's what we call them in the trials that we did to support their approval: lecanemab and donanemab. Lecanemab made by Eisai, donanemab made by Eli Lilly. The drugs are incredibly biologically powerful in that they both lower amyloid levels to a quote-unquote normal level in most patients when treatment is extended adequate duration. And again, you said it, we had numerous quote-unquote real-world data presentations from clinicians who are using these drugs in their practices now and tracking how it's going. And my general summary of those presentations, and I did try to attend several of them, and there were several of them, is that things are going incredibly well, perhaps even better than expected. The safety data so far for these drugs has turned out to be perhaps even better than the safety observations during the trials, which is a great relief, because there are serious side effects that can occur with these drugs, and we should not underestimate the risk of those or undervalue the importance of them when people are choosing whether or not to go on these therapies. But so far, the real world safety data is pretty compelling and not altogether different from what was observed in the trial. So that was deemed good news. The trials, of course, are the only way to really get evidence around efficacy. And the reason is that in the trials, we're comparing people who get the drug to a matched population. Randomization generally does its job. And half the people in the trials got the drug and half of the people in the trials got placebo. And so we can assume that differences between the arms of the trial are due to the drug because populations are matched in every other way. And in those trials, the evidence for efficacy was compelling. People who were on drug showed less worsening over time compared to people who got placebo, and that's why the drugs were approved. In the real world evidence, we don't have that comparator arm, although we did see some pretty compelling long-term extension data for both of those drugs from the makers of the two antibodies, in addition to the real-world evidence from clinicians. So both sets of data are really kind of align on the general kind of stance of what we're observing so far. One, the efficacy in the real world, that is the slowing of disease progression, looks pretty good and is increasingly convincing to me that these, in fact, are disease-modifying therapies. That is, that they actually slow the rate of progression of disease over time. And the best evidence from the meeting to support that did come from the open label extension studies, where people who had drug the whole time did better than people who switched to drug after 18 months on placebo. So the fact that those folks never catch up with the people who had the longer exposure to drug is pretty convincing evidence to support disease modification. Not the most possible convincing, because it wasn't a prospective study that tested that explicit hypothesis, but nonetheless important data. And then in the real world setting, we're seeing that patients are, again, progressing over time, apparently progressing more slowly. But what stood out to me in the presentations was the apparent trend, pretty striking trend, that when people are on drug earlier in the course of the disease, they progress far less than if they're started on drug later in the disease. Now, this isn't necessarily evidence of disease modification. It's more evidence around the idea that early intervention is important when neurodegeneration is less, perhaps when fewer plaques and tangles are present in the brain. But whatever the reason, it does look like early intervention is key to maximizing the value of these treatments. And while overall on a group level, we see that people definitely do continue to get worse, but hopefully get worse more slowly on these drugs, there were even some suggestions at the meeting that if the disease is caught early enough, people may not be progressing, or could even in rare occurrences show some improvement over time when they're on these new drugs. Now, all of this is wonderful and exciting, certainly important. There were also presentations in the real world setting about who's getting access to these drugs, and not surprisingly, these drugs are not being utilized equitably around the country. And we know that there are barriers to using these treatments. You have to have that gold standard demonstration of amyloid present in the brain. Hopefully the biomarkers will make it easier for people to go on these therapies and go on them earlier. The distribution of expert clinicians around the country is not homogeneous. We have concentrations of experts in big cities and the like. And so there's still plenty of work to be done. And we did see some data for a subcutaneous version of one of these drugs, which is also very exciting, pretty compelling, and could really increase accessibility for these medications longer term in the future.
Great. Maybe we have time for one more question. Okay. Any new treatments on the horizon that you're excited about?
Yeah, we definitely saw some exciting data for new treatments. The easiest one to explain in our limited time would be what I view as potentially the next amyloid lowering drug. For these antibodies that have now been approved and that I've been gushing over for the last 10 minutes or so, very little of the antibody actually makes it into the brain. And so we saw the latest set of data for another antibody called trontinemab, which is a monoclonal antibody against the amyloid beta protein that's attached to a transferrin receptor molecule. And putting the mumbo jumbo aside, the attachment to that molecule helps the drug actually get into the brain. And it seems to whoppingly get more drug into the brain, such that you need a lot less antibody to be infused into the bloodstream to have much greater access to the brain. And so we saw the latest evidence for trontinemab suggesting that it can dramatically lower amyloid, perhaps faster than any other monoclonal antibody. Now, I'm not supposed to say things like that because they haven't done head-to-head studies, but the timeline to lowering amyloid below elevated levels for trontinemab is extremely impressive. And so we're excited to continue to follow this story. They're going to do phase 3 trials of trontinemab in early AD, and they are also planning to do a quote unquote preclinical AD trial, which we've been a part of here at UCI MIND. There are ongoing preclinical AD trials of lecanemab and donanemab already. And we're very excited to see the results of those, though they're still about 3 years away. But it'd also be extremely exciting to eventually see results of testing trontinemab in preclinical disease, that is, in people who have amyloid building up, but their memory performance is still normal.
Excellent. Thank you, Dr. Grell. I appreciate you joining us today.
Thank you, and I hope our UCI MIND community is enjoying this series. We are always eager to hear from you. We take it very seriously to be bringing information about the current state of the art and the progress we're making as a field to our community of participants, advocates, supporters, and just generally interested people. So it's always our pleasure to have the opportunity to share about our mission and about the progress we're making.
I couldn't have said it better. Thank you, everyone. Next month, we'll be chatting with Senior Health about the guide model and the Care Navigator program. To learn more about UCI MIND, visit our website. If you're interested in learning more about research, also visit our website or go to c2c.uci.edu. Take care, and we'll see you next month for Ask the Doc. Take care, everyone. Bye-bye.